I'd like to invite Dr. Reena George for moderating the session on cost-effective care at a secondary hospital setting by Dr. Thomas Ram.
Good afternoon, and thank you for having this session on oncology in this conference. While not as common as diabetes or hypertension, in terms of mortality, financial toxicity, and time toxicity, it does remain a problem for the person who is unfortunately affected. And I'm very grateful that Dr. Thomas Samuel Ram will be speaking to us on this topic. Dr. Thomas is the professor and head of radiation oncology at the Ida B. Cancer Center in CMC Vellore, and has just recently finished a term as associate director for missions at CMC Vellore. Besides his academic and administrative responsibilities, which are quite remarkable, he has been committed to reaching out to secondary care settings, and this is evidenced by his work as a visiting oncologist in several small cancer centers ranging from Kakinada to Meghalaya. And he has also showcased his interest in this field by participating in cancer camps both in Tamil Nadu and in Madhya Pradesh. So I invite Dr. Thomas Samuel Ram to speak to us on cost-effective care in oncology at a secondary hospital setting. Thank you.
Thank you, Dr. Reena, for those kind words of introduction. I'd like to also take this moment to thank organizers of this unique conference, Dr. Anand Zak, for giving me this privilege to speak on this topic, which was more of a self-learning and self-reflection for me personally. So I have this topic which has been asked to share is on cost-effective care at secondary hospital setting. So as I was reflecting and going through, what I should share, certain things were going through my mind, and we keep talking about equity, distributive justice, and things like that. So one of the quote which I want to start my session and share with all of you is by Martin Luther King, who said, "Of all the forms of inequality, injustice in health is the most shocking and inhumane." Indeed, it is shocking when we see, as Dr. Reena mentioned, as we travel to various parts of the country and not only see our mission hospital network, but also other NGOs who are working in remote places. And I think, are you from Gadchiroli? Because I was there in Gadchiroli and had a chance to visit Search and also visit some other NGOs in Maharashtra. So it is appalling to see what all can happen in this remote healthcare settings in our country. So I just want to share, I'm presuming most of you are from the non-oncology background, and just to give you a overview, the global cancer burden is about 10 million deaths in 2020. There are some of the commonest malignancies we have: breast cancers, lung cancers, and in our country, again, because of the perils of tobacco, we have a lot of head and neck, especially oral malignancies in central part of India, where Bhopal still continues to be the tobacco capital. And then we have cervical cancer incidence was quite high, but with all the interventions and the policies, gradually we see a decrease in the incidence and prevalence of cervical cancer across the globe, and especially in our country. And almost 1/3 of the deaths which I'm talking about are because of these addictions. High body mass index, alcohol continues to play a role, and the dietary factors which are there, and lack of physical activity. And there are certain malignancies which are linked with infections, especially the HPV infections, hepatitis, again, which contributes to almost 30% of the cancer cases in the low and low middle income countries. So most of these cancers now we have the whole care pathways. If we intervene or interject at the right time, even at the early detection, screening, or at the definitive treatment, most of them can be cured if detected early and treated effectively. And if you see this global map of estimated age standardized incidence rates, which is in 2020, and it ranges from more than 250 per 100,000 to around 100 per 100,000. And at India, we are somewhere pegged at about 97, which is almost close to 100 incidences per 100,000 population. And partly, I still feel that it is partly because of underreporting, because we do not have, like, it's mandatory notifiable to have a cancer diagnosed at a small clinic or in a big hospital. So the cancer burden in India continues to grow. We have a crude rate as per ICMR is 100 per 100,000. And the estimated number of incidents of cancer cases in 2022 was almost 1.4 million. And also WHO has a similar estimates in our country. But by year 2025, it is projected there'll be increase in 30% of the incidents, where we are inching close to 1.7 million, and there'll be close to 1 million deaths because of cancer. So that's the enormous problem we have at hand, where cancer as part of NCD, which we need to face and be prepared how to address this growing burden of cancer in India. Again, just want to show you the map. Again, if you see the health index in India, again, this is published by Niti Aayog. Most of the states in central and northeast, and also UP, Bihar, they are having a very poor health performance index. And again, on the left, what you see, there is a map of age standard incidence. You see there's high incidence rates stated in the Northeast. And some of these states are actually known as the cancer capital of our country. But again, most of the states, what you're seeing, they have very few cancer or oncology related facilities, and probably there will be a lot of underreporting happening in these states. So when we talk about cancer care, most often it comes to our mind that the patient is going for surgery, or they're going for chemotherapy or some radiation therapy. We think of only like a definitive treatment comes to our mind. But I just want to share with, again, this audience, that it is a continuum which can start right from preventive oncology, education, awareness, to early diagnosis, prompt referral, the surgical oncology, then the definitive component comes in, surgical, medical, radiation therapy. And then often we forget about survivorship. Once we finish treatment, we tell the patient, go home. But we are not looking into what the patients are going to do beyond the definitive cancer care. So survivorship is actually a huge thing, but I think most of us in our centers, we hardly focus on that. And also early referral to palliative care is a key component. The moment we know the patients are having a recurrence or early relapse, often we found that patients are referred. Palliative care is sometimes looked upon only as end of life care. So again, that is the misconception we have. And then also it's important to have an understanding of what is end of life care, especially in our context, the culture of our country. And also we often forget that as physicians, clinicians, oncologists, we say advocacy is not our expertise, why we should put our head and time into it. But advocacy in oncology is very, very important. So that completes most of it. What I've shared here is what is understanding of a comprehensive cancer care. So some of you, I know that they are working in a primary care setup or a secondary care setup, or maybe in tertiary care setup, but there's no oncology. So the moment I have been asked questions and like, how can we develop cancer care? So the moment we talk about cancer care, again, people think of, shall we have surgical oncology, chemotherapy, and radiation oncology? That's again, those three things come up. But actually cancer care, the first important thing is make some register wherever you are. Either is patient diagnosed in your setup or referred from somewhere with some vague diagnosis of malignancy. If you have like a register, or you may call it like a hospital registry, that's the first thing to estimate the volume of cancer service which you need to develop. And some of the simpler things to do and take forward, you may have nursing program, or you'll have nurses, is to do preventive oncology. And again, palliative care, because you may not have definitive cancer treatment options, but in that surrounding area, you'll have a lot of patients who had cancer and they need some kind of a palliative and supportive care. So these three things on the top are maybe more simpler and easier to implement, because also the cost which you need to incur on that is relatively less. Then comes the definitive cancer care pathways, the cancer chemotherapy, surgical oncology. And then if these two develop enough, because radiation oncology is a very resource intensive specialty, and most of the equipments can be very, very expensive. So that can complete the picture, because the moment you have radiation oncology, people know that the whole care pathway is looked after in a particular setup. So that also adds value to the institution. So as I'm going to share with this background of the burden of cancer and what we mean by comprehensive cancer care, I'll be sharing on cost-effective care at a secondary hospital setting. And the overview which I want to take you through is, again, it was for my own understanding, what is healthcare equity or inequity we're talking about, and what contributes to this inequities. Then because of this, what is the consequences, and what could be the strategies, and what are the clinical approaches which we can think of. And I will be sharing some of our own personal experience from CMC about some clinical social cases where we address some of these inequities in a healthcare systems. And also like to conclude by what is the relevance of this cost-effective care in oncology to a UG and a postgraduate education. So we all know about health equity, and there are fairly standard, I can say, understanding and definitions, like in WHO defines as the absence of unfair, avoidable, or remediable differences among groups of people, whether those groups are defined socially, economically, demographically, or geographically, or other dimensions of inequality. And also they said the health equity is achieved when everyone can attain their full potential for health and well-being. It sounds like an utopian dream, but I think it gives you a direction actually where you should think of when you're thinking of healthcare equity. So what are the factors which can bring in this inequities in healthcare? So again, you can look at various things, but there can be patient factors, and there can be factors within our system and the policies what we have. So patient obviously is very, very obvious. It's the socioeconomic status of the patient, the race, ethnicity of the patients, the geography where they come from. And though we know that CMC is one of the well-known healthcare facility, but we have our own issues with geography. We have patients actually even this in the tribal belt around Vellore from Javadi Hills. Even if we give completely or write off for the treatment, they find it very difficult even to come here for treatment. And then we have those gender biases for access to healthcare, and systems and policies. Again, we find that there might be a cancer service in a particular place, but there will be inadequate infrastructure, lack of trained personnel. We just heard that many people are not trained, and sometimes they over treat or over diagnose the patient or investigate, and that can lead to a lot of financial toxicity. And also, if we do not adhere to certain treatment guidelines, again, it can lead to some mismanagement and can add to the cost of the patient in oncology. So what could be the consequences of this inequities? So the first thing which can happen is, if their patients are not adequately managed, appropriately managed, it will definitely lead to increase mortality and increase cancer incidence, poorer quality of life for the patients, financial toxicity, which we heard in the previous speaker also, and also reduced economic productivity, not only of the patient, because the patient often in a setting of Vellore, they come with the whole family. At least there'll be one earning member along with the patient, and often we see not only on the patient's job is lost, but sometimes their children, a son or a daughter, they were in a good job, and because they are spending at least 2 to 3 months in Vellore, they often have to lose their own job. So that's a huge downstream cascading effect if things are not done right in the beginning. So how can we address some of these inequities what we are talking about? And one of the things which I like to share, and which should be the focus of my sharing here, is what are the clinical approaches we can take to ensure equity and addressing health disparities. So some of the things which I want to share about clinical approaches is, it is very critical and important to address the social determinants of health. I mean, especially in a tertiary care setup or even a secondary care setup, you will be so caught up with the definitive approach of diagnosis or the treatment that we do not understand the context about from where the patient or the family is coming. I mean, we straight away jump into, we will open one reference manual or a guideline and just go to it and very textually approach the whole thing rather than contextually approaching the whole thing. So it's very important that we understand the social determinants of health, and also we need to have culturally oriented and competent care. Again, especially in a country like ours, there are a lot of cultural barriers and I would say health-seeking behaviors of patients. I was surprised. I mean, I was visiting some places in Maharashtra, and I realized that there are patients who specifically seek a particular doctor by the particular surnames they have. So it was very interesting to understand the health-seeking behavior is defined by the which caste, even the physicians are coming from. So it was a learning for me. So we need to understand some of these things which can still happen in our country. So that is very important. And also we need to implement patient-centered navigation services. I'll be sharing a little bit detail about what is navigation services. But again, especially when patients say come to our setup, it is very easy for us to tell the patient, especially in a CMC setting, and say go and do CT scan, blood test, urine test, everything. And most of us, if you tell us to go, we ourselves will be lost. So appropriately identifying which category of patients need to be guided and navigating them through a healthcare system, right from the initial consultation to the subsequent evaluation and the treatment and the follow-up care is very, very important. And the other important thing which we need to be, I would say, careful and cognizant of this is to address some implicit biases in cancer care. Again, often we might see that if you're a multi-specialty setup, and if a patient has come with, say, a diagnosis of cancer, especially if they're vulnerable because of social or financial reasons, often as the clinicians, we might say, anyway, this patient has cancer, maybe it's a low priority, maybe we should, redirect our resources to something else. And, anyway, the outcome is going to be poor. And without having a proper understanding of the biology of the particular cancer, often it is inherent, I think, as clinicians, that we can have an implicit bias when we are looking into cancer care. Another important component of clinical approaches is to encourage patients for increased participation in clinical trials, as it's very important to ask what are the relevant questions and what are contextual to that particular environment where we are practicing, and also where the patients come from. In fact, I am surprised that sometimes, often the patients are the one who give me the questions for research. And I think it's very important, I think, to people who are young in the audience, sometimes we impose our research question on the patient, right? But I think we should be aware of the fact, if you communicate enough with the patients, because nowadays they are also reading well and they know various things. So like simple thing, patients will ask, doctor, is there any test available which will tell me ahead of time whether my cancer is coming back or not? I mean, there are some research going on, but these are the people who are asking us on the future of medicine. So it's very important to understand their perspective. So increased participation in clinical trials, it should be contextual and relevant to our environment, is going to be very, very important as we approach this problem clinically. So when we address the social determinants, it's very important for us as clinicians, and when we communicate with the students, is to identify and assess those factors. Again, I said that we are so textual based on the guidelines which are published very regularly that we forget to even ask the patient what is their occupation, while they are away, who's managing the home, who's accompanying you, who's the relative with the patient, especially in our context of what we practice in Vellore. So it's important for us to keep reminding before we impose, the guidelines which are published mainly from the Western world, to understand these factors in the patient. And also promote, which I had shared about navigation programs of the patient. And also it is important to collaborate with the outreach setups around us, the community outreach around, also the NGOs or organizations around us. And it is helpful again for us in a context is we have outreach clinics around Vellore, and we have outreach mission hospitals across the country. So we do some kind of networking with those clinics, and it's really, really helpful for us as this collaboration is working well for us. And also we should advocate for policy changes as clinicians, because that is what will have a downstream effect many years down the line. So how do we look into this, addressing this inequity? Again, if you are in a teaching organization and a tertiary organization like Velo, how can we strengthen our primary and secondary care? So I just want to share a few points and give you some examples from our own personal experience. And it is very important that we strengthen, because we need to decentralize, and we are looking at various ways to decentralize, because if you know, the moment you say cancer care, it is all comes into the cities, right? And most of the cancer care you'll mostly in the South India, I can say Western India and the Delhi NCR region. And there is very under representation of cancer care in, the Bihar, Orissa, and also maybe in the Northeast. So it's very important as we address this rising cancer burden, we look at the whole continuum of cancer care. It's not only about sophisticated surgery or, very expensive chemotherapy costing 2 lakhs per month, or radiation therapy costing about 3 to 5 lakhs for a course, but also we need to focus on early detection and prevention, which can be easily done in a primary and a secondary care setting, and also improve the cancer care quality. As we heard, it is to have some regular educational sessions, and we need to do regular CMEs in the various aspects of oncology. And there is a huge gap in the shortage of oncologists. People are getting trained. We have now huge number of radiation oncologists coming out. And what we have moved from an era of a general oncologist, I think you also all face this problem where very few people are in general medicine and more people are on DM courses, right? So we are also facing the problem. We have a training which was more like a general oncologist, and now we have a shortage of oncologists in various places. So also we need to promote multidisciplinary tumor boards, where this discipline of discussing with each specialty should be there, and promoting cancer research. I just want to quickly share, I think I have been told I have 5 minutes. I'll try to quickly finish in 5 minutes. And that we have this network of our mission hospitals across the country in various states. And this is a map of some of the mission hospitals who have some cancer services, and some of them had radiation therapy facilities. So as I come from a radiation oncology department, and we adopted 1 or 2 centers. And if you know Dimapur, which is in Nagaland, it was started partnership in 2005. And within 5 years, our department adopted a visiting every 3 to 4 years. And today now there is a full-fledged cancer services there. And they have chemotherapy, palliative care, radiation oncology machine. They're in fact looking for a second machine. They're getting a PET CT scan and also an MRI CT scan. So it's almost more than 10 to 12 years of adopting that place sincerely and showing affirmative action. Today we have a facility at Dimapur. So like that, we keep going for some camps into various smaller places, and we're hoping they also follow the path which Dimapur has taken. So I just want to come to quickly, maybe if possible, 1 or 2 patients. We had one 43-year-old widow from Velo, and she came with wide discharge, and she came from a very low socioeconomic status, and she was working as a house help in one place, and she had a very poor social support when she approached us. And we evaluated this patient, and she had a growth in the cervix. It was a cervical cancer. And these kind of patients, when they do come to us, we do a clinical evaluation and we order some investigation where we need to do something called staging for these patients. And her tumor was a little bit of the bad biology. It is adenocarcinoma. So the standard treatment is you have to start some chemotherapy because it was a bulky tumor. It was discussed in the tumor board, and this patient also got was recommended for chemoradiation and followed by brachytherapy. So when we list down our estimated cost for this kind of a patient comes anything between 3.5 to 4 lakhs. And this patient, remember, was helping in the house. So our social worker assessed her, and then we said, can we do the standard of care, which probably should have got in any good centers in the world. So we are lucky that we had some provisions for funds for cancer patients. So we use those funds to give her 4 cycles of chemotherapy. And there's like filling in the gap, there's a society called India Cancer Society, which applied for grant. They send about 2.8 lakhs from there. And then because of this various integration of the cancer care pathway and reaching out to social worker, visiting, finding out from the home situation, this patient got one of the best cares which she would have got in any good centers, not only in the country, but anywhere overseas. So she got the standard of care, and she's just had her brachytherapy and we're waiting for the outcome. Second patient was 52-year-old. Again, I said outreach we have in Chittoor. She came to us, again, cervical cancer, assessed by a social worker. We arranged for a low-cost residence in a place called Chatram. She started radiation, and then she disappeared after 6 fractions of radiation. So you're wondering what is happening. Because we are networked with the outreach center, we send our team from Chittoor. They visited her home, then realized she's almost like living on her own, and all her relatives had abandoned her. And then she was brought back to us. We reassessed. Luckily, the disease was the same status. And we did a lot of counseling with this patient and the family. In fact, Chittoor was generous enough to give us stay in Chittoor CMC campus canteen. And a dedicated social worker was always with her. And we arranged her food while she was in Vellore. They arranged the food while she was in Chittoor. And some of the side effects were managed to, again, through our funds, what we raised. So again, she had a full standard of care which a patient will get in Western world. So what I reflected on this, as I showed in my previous slide, we addressed her social determinants of health. We found out where she's coming from, and it was for my whole team. They were oriented to the cultural where she came from, and they were competent to give the care. And there was amazing patient-centered navigation service, not only from here, but coordination with Chittoor campus. And we addressed it because we had a situation, patient is alone, nobody, she's abandoned in the family. Should we do just palliative treatment or go for the definitive curative treatment? And then we overcame my implicit bias and we gave her the best standard of care for this patient. So as we continue to look into the addressing the healthcare inequities, I think some of you have heard the CMC model of both and these two classic examples of what we are able to do was a world-class care at an affordable cost. So there are many more schemes, which is the PMJ scheme, which can help in offsetting the cost, reducing the financial toxicity to the patients. Quickly on to the relevance of oncology to our undergraduate and postgraduate students of medicine. Why is important is they should understand the impact of this health disparities on the cancer outcomes, and we should develop culturally competent students with communication skills, and they should also be able to understand navigating the complexities of the healthcare system and recognizing what could be the implicit bias and promoting evidence-based prevention strategies. So we continue to have engagement with MBBS, postgraduates, nursing, AHS. In fact, people who do management in CMC, they come for oncology exposure at CMC. So NMC also has integrated oncology and radiotherapy in a very structured manner. And I'll quickly run through the slides. And this is a slide which I want to share about the cancer care pathway, where we are only part of the definitive treatment, but there's a whole spectrum of cancer care pathway, which everybody can play a very important role in these things. Since I don't have time, I'll just quickly conclude my talk, where I want to share that we are all part of the journey towards this SDG goal. And by 2030, we need to reduce by 1/3 the premature mortality from cancer and other NCDs. So whatever I have talked about, how we can integrate with that is going to be very, very important. And similarly for cervical cancer, we have a goal of 2030 of 90, 70, 90. Of 90% girls should be vaccinated, 70% should have been screened, and 90% should have access to appropriate treatment who have been diagnosed to have cervical cancer. So to summarize, we need to have early integration of oncology in education, reorient education, care, research to the needs of secondary and primary care settings, and also to have that orientation not only as practitioners, but also at the education level of the social determinants of health, and have a resource stratified approach, again, not only in the treatment, but also in a teaching about in various scenarios, how we can evaluate, diagnose, and plan the treatment. And also we should align what we are doing is with the National Cancer Control Program, also with the sustainable development goals which are laid before us. So with this, I'd like to thank you for your kind attention, and I'll be happy in case there are any queries or clarification.
Thank you, Dr. Thomas, for such a wide overview of the various aspects of this equity in cancer care. We'll start with one question that's come from the audience. This is about the Kachar Cancer Center in Silchar. Dr. Ravi Kannan recently got the Magsaysay Award for that. And the question is, how replicable is the cancer care model of Kachar Cancer Hospital at Silchar in Assam in other parts of the country?
Thank you who has asked that question. And I was privileged to spend time with Dr. Ravi Kannan. I stayed with him in his home, and I visited on my Northeast tour. I've been to Kachar. And Kachar is, again, an interesting model of low resource setting, how we can do high quality care. And again, coming from the cancer care pathway which I showed, though he's a surgical oncologist, but he was very much into all the continuum of cancer care, what I'm talking about, from preventive oncology to palliative care. And also his approach was whatever the guideline will suggest. Guidelines nowadays give you very expensive chemotherapy options we have, but he had optimized the guidelines. If this is not available, what can be done, and what is available in his over places. So I think his attitude to adapt to the resources, I would say that is important. I think if somebody wants to develop that kind of a model in some other place, wherever you are, I mean, even if you're in a city or even in your remote places like Kachar, I think it's your attitude, whether you're willing to adapt, be relevant to the environment where you're going to work. I think that is going to be very important. I think he has demonstrated. I'll give you a small example of head and neck cancer. When I was there, he had only had a cobalt machine. Cobalt machine is like, if you talk to surgeons, they say you're burning the patients. That's the classic statement surgeons will tell us. But on cobalt machine, he was treating head and neck cancers. And though it is not used very commonly because you have these modern gadgets available, but they have something called tissue compensator blocks. So they were still using tissue compensator blocks, and the skin toxicity, which normally you'll see dark skin, burnt skin, I have not seen in those kind of patients. And they also published their data. It takes an effort to do that, but even he demonstrated that even in today's time, a machine which is outdated, like a cobalt 60 machine, they are still recently using that machine and having a reasonably good outcome. So again, adaptability, taking more effort to be technically sound and right what is needed, I think is possible to do that model.
Are there any other questions? If not, I'd just like to make a comment connecting with that. I think a treatment that the patient completes, even if it is second best, is better than the very best if they don't complete it or if they can't access it. And oncology is a very clear example of that. And the buzzword often is burdens versus benefits. Dr. Thomas had talked about maintaining a registry wherever you are. And it could be worthwhile also to be connected with a couple of oncologists, one in a not-for-profit, one in a regional cancer center. And the common cancers that come to you and who are registered in your registry, just to discuss with a trustworthy oncologist what the prognosis is and how worthwhile treatment is and what is a cost-effective treatment. And your own place might be a good place to pick out people who are dropping out of treatment. If you just keep track of them, curable cancer patients who abandon treatment, if they're picked up in the community, you can save lives even without having the equipment. The other couple of resources which are now quite helpful, you must be aware of the National Cancer Grid. And the National Cancer Grid is a good resource, not only in terms of the centers that are available, but you can get an online second opinion, upload the reports and get an opinion. And it gives you a directory of services. You have resource stratified guidelines. Like long back, Dr. Maman Chandy had 3 protocols, well-to-do, middle class, and poor. and each of those were evidence-based. One more thing that might be a useful resource is, from the palliative care perspective, is Pallium India. And not only do they have educational resources, they also have a helpline. So patients or doctors can contact them if they want advice regarding a particular patient. I think it works 8 to 5. So I just wanted to share those couple of comments. And is there any other question, or we have a couple of minutes left? If not, thank you, Dr. Thomas, and thank you to the organizing team.
I request Dr. Reena to present a memento to Dr. Thomas Ram.